So this is a patient, also relatively youngish. Actually, this is older patient, 75-year-old with family history of premature CAD. So outpatient cardiology, some statin question, and some PCSK9. She mentioned some subtle symptoms. So patient ended up coming for a calcium score and coronary CTA that was done after. By the way, this is a question will come to you sometime. If patient has calcium positive, whatever, should we do coronary CTA? The guideline says no in the absence of symptoms. The other question is, should we repeat the calcium score 2-3 years after? And the answer is no. Statin therapy a lot of time will stabilize the plaque, so the calcium might go up just by nature. So the answer is you never repeat the calcium score a few years after. Just the point, statin therapy can stabilize plaque. Anyway, so this patient ended up with a coronary CTA. This is just to show you how the plaque analysis. This is, I think, this is the heart flow model, and you can really navigate. So this is me now. I'm navigating the left main, coming down to the LAD. You start seeing some lesion here. It just shows you that the yellow is non-calcified and the blue is calcified. So this is non-calcified plaque, comes down, down, down. So this is even, we have not looked at the CT. I'm sorry, I feel like I jumped. So the question is that lesion significant? So let's go to the actual CTA. So let's go ahead and let's give you a minute or so to look at the LAD that I already kind of told you about. And again, I'm gonna do it the MPR way. We see the lesion and we will double oblique it and understand that lesion. There's some plaque in the LAD. So this is LAD non-obstructive, I would say. Okay. Now I see the trouble. So I think that was maybe a different, the FFR was wrong. So the plaque analysis was not labeled correctly. Anyway, so the LAD looks okay, some mild disease just for the time. Circ gives an OM and it dies off. So it's a small non-dominant circ. Let's go to the RCA. Again, if you want to do the MPR, if you want to do the CPR, but I'm just gonna again scroll from the top, just have that habit to kind of screen arteries on the axial. So we scroll down and you start seeing some non-calcified plaques. Now we pay attention to the proximal, to the mid segment, and look at this here. There's a tightness. Is the artery just small or something off? So let's go there and carry our alt, the crosshair, double oblique it there. And from here, you will just double oblique. So how would you call this lesion? How would you describe this lesion? Is this severe, moderate? Okay, so we talked about it in the morning. When this looks almost gone, the artery is almost like occluded. The question is this severe / subtotal occlusion versus CTO? So one of the tricks we did in the morning was we looked at the gradient, right? Or the difference of the Hounsfield unit distal to the artery, if it goes down naturally or it goes the other way, i.e. it start going the other way from the distal to the proximal because some collateral. So this is that lesion that we are concerned about. If you see my cursor, again, is that subtotal like 99% versus a CTO. So I went here and I put the Hounsfield unit. I went just distal to it and I'm getting about 1298, so 1300. And when you go more distal, it's 1100, 1131. So it's going the expected way, which means the contrast still passing through that lesion and decreasing gradually over time. So this argues against a CTO. So we ended up calling this as a severe subtotal or almost 99% stenosis. So now I take you back to the PowerPoint. I think that now my fault, you see the mark here, this is RCA. So this was an RCA. So if I go to that lesion, we can understand that lesion better. So it's almost purely non-calcified, and you see how tight it gets there on the cross-section of the plaque analysis. And I think this is a good tool. One, you understand how the artery is pathologic, how long, but also it gives you an understanding how far it is from the ostium. So if you look here carefully, you see the number it gives you. So this lesion was about, if I go back here, this lesion was about 30 millimeters, so 3 centimeters from the ostium. So sometimes also for our interventional colleagues, we tell them where the lesion is, and it's really good technology nowadays. And this is the total plaque. So imagine this is a patient with a total plaque of 139. So if you go to the previous staging system, this would be moderate. But what more important, this is mostly non-calcified plaque. So it is really a lipid-rich plaque. We did the CT-FFR, and there's a significant drop. So that's another thing. I think Dr. Lima mentioned the gradual versus the sudden drop. We go by what we call the delta CT-FFR. A lot of really, like, I think anything above the 0.10, 0.12, especially across that lesion, like 5-10 millimeter proximal to the distal, if there's a significant drop, like here you see how it was 0.99, and then it goes dramatically to like significant number. That's a focal stenosis, as we saw. So the patient went for a heart cath, and exactly as we described there, you see that focal lesion, almost 99% stenosis. So patient went for a stent and did very well. Anyway, so I'm gonna stop here for questions. So the CT-FFR relies on a few concepts. One, especially if you scan prospective. So the prospective, the way it acquires, it writes the step and shoot, right? So there will be one chunk of data, and then the table will move. You get the next one and the next one. So the way we train our trainees and technologists, when you plan it, you don't go too high, right? And the reason is if you go too high above the carina and you do prospective, the next acquisition will truncate the left main. Like sometime that might be significant motion, and the CT-FFR relies on a perfectly imaged left main. So if you truncate your left main, your CT-FFR cannot be used. So always don't compromise the height. Don't go too high if you're gonna assess for CAD, unless you're looking for cabbage, crafts, different story, in prospective acquisition. The second part you need to keep in mind is the distal LAD. You have to some degree distal/apical LAD to use it for the CT-FFR. If the LAD is not included enough, CT-FFR cannot run. They have to simulate the numbers by having that. The third part is the nitroglycerin. I cannot emphasize enough. Nitroglycerin is so important for the disease assessment, but the CT-FFR relies on the, actually, I believe in the 0.8. I know people sometimes say 0.4 can be used, but I've seen it. The gradual decrease becomes more an issue when you have the 0.4. So I'm a big fan of the 0.8, and that's one of the reasons is the CT-FFR. And again, try to understand the lesions across the artery. Don't take an absolute value, i.e. apical LAD. A lot of time for a mild, moderate disease across the LAD is going to get to the 0.74, 0.75. So try to understand if there is a focal lesion with a significant drop in the CT-FFR.